Hello and welcome to Avisena's webinar entitled Coding Changes for 2012. So the agenda for today's webinar is to first discuss the changes that we see in 2012 coming from Medicare, and we'll detail all of those items. Next, we'll transition to the changes relevant to ICD-9, and then finally we'll spend some time looking at the CPT code changes for 2012. At this time, I'd like to introduce Wendy Frierson. She is Avisena's Director of Compliance and Education. She is an AHIMA certified ICD-10 instructor. Welcome, Wendy.
Good afternoon, and thank you for attending our webinar on the 2012 CPT code changes. Today we're going to discuss the 2012 fee schedule, also the 2-month patch, and the Medicare deductible. The 2012 final schedule was released on November 21st and published on November 28th with a reduction of 27.4% with a proposed conversion factor of $24.70. Under the 2011 fee schedule, our current conversion factor is $34. So that's a huge decrease. So Congress announced a 2-month patch, meaning for the first 2 months we will continue to use the 2011 fee schedule. Congress will make a decision if they're going to move forward with the 27.4% reduction on March 1st. And as far as our Medicare Part B deductible, it was decreased. So now the beneficiaries are now responsible for $140 annual, and Medicare will pay the 80% of the allowable charges for the covered services. On this slide, we're going to talk about the proposed changes for 2012. Now we have the enrollment. CMS is focusing on the enrollment as a way to prevent fraud. The ordering and referring physicians edits has been placed on hold, and we do not have an implementation date for the second phase. For the Advanced Diagnostic Imaging Accreditation, anyone that's performing procedures within the scope of the diagnostic imaging procedures will be required to become accredited. The accrediting body will submit the updated information to the suppliers. So again, providers, if you're providing any of those procedures, you need to make sure that you complete your accreditation application. Also, the new Medicare Revalidation Initiative. CMS will revalidate all Medicare providers by March of 2015. It was originally scheduled for 2013. CMS decided to extend the completion date due to all the stakeholders concerned. Providers, you will receive letters from CMS. You have 60 days to respond to the revalidation request. So providers, please be on the lookout for these letters. If the letters are not completed, if Medicare does not receive your revalidation process within the 60-day request, your number will be deactivated. So again, look out for those letters. Also, under the Medicare changes for 2012, we have the ABN revision. Providers, make sure that you're using the ABN that was released on 3/2011. If you're using the ABN that the release date of 3/2008, this ABN will be considered invalid. We have listed the link here if you need to go onto the link to download the new ABN, but this ABN should have been used as of January 1st, 2012. Also, under some of the changes in 2012, we had a few RVUs that were affected. The radiation oncology will see a 6% decrease to their reimbursement, and this is due to the claims submitted to CMS. And radiation oncology was on the OIG work plan for 2 years. So if you're performing or if you're within this specialty, you will see a 6% decrease. For cardiovascular providers, CMS will scale the malpractice RVU for 19 thoracic and cardiothoracic surgical codes to reflect the specialty risk factor. So they're looking at these procedures to make sure that they have allocated enough malpractice to associate this RVU. So you may see a decrease. It's not 100%. And for codes that have disvalued, they're actually now being reviewed by Congress. Congress will finalize a proposal to review the high expenditure, the overutilized codes to see if they need to make changes to the RVUs. Congress did not finalize a proposal to review the E&M codes to see if they will fall up under any changes due to RVUs. So again, the specialty that was affected the most is radiation oncologists and cardiovascular physicians. There are 19 procedures that the government is looking at, and they may affect your RVUs. The 2012 fee schedule also impacts the multiple procedure payment reduction. The multiple procedure payment reduction is a policy that works by reducing only the practice expense portion of the payment for therapies and procedures when more than one unit or more than one therapy or procedure is provided to the same patient on the same date of service. The 25% reduction will be for the second procedure and subsequent services, again performed on the same patient during the same session. This means that the Medicare procedure payment reduction applies to multiple procedures as well as multiple units of therapy. This policy is written by Medicare, but it is adopted by some commercial carriers such as Aetna, and United Healthcare stated that they will also adopt this policy as of March 2012. So providers, you want to make sure and follow up with your carriers to see if they're going to adopt the Medicare multiple procedure payment reduction. Also under Medicare, we have changes for the 2012. We now have 2 new health risk assessments. We have HCPCS code G0438, which is the annual wellness visit for the first visit, and it's equal to the 99204. The good thing about it is we had a 5% increase in reimbursement. We also have the 64039, the annual wellness visit, which is your subsequent visit, which is equal to the 99214, and there was a 3% increase. Reminder, providers, there's no out-of-pocket expense to the beneficiaries. However, under the healthcare risk assessment, there are guidelines that you must follow. And here are just a few documentation requirements. You need the demographics data, you need the self-assessment of the health status, you need the psychosocial risk, you need the behavioral risk, the ADLs, which is your activities of daily living, and your IADLs, which are your instrumental activity daily livings. There's no form, however, CMS will provide guidance on the documentation, but again, you must make sure that you're documenting the following information that I've just mentioned into your progress notes. Also, we did receive an increase in the RVUs for these 2 procedures, meaning more reimbursement. Also, Medicare is also covering behavior therapy for obesity, depression, alcohol. These are now new covered services by Medicare, and the link will be listed on the resource page. So again, we have some new services for Medicare recipients effective January 1st, 2012. Under the Medicare changes for 2012, we now have a new modifier. The new modifier is 33. The modifier 33 is used with preventive services, and the purpose of this modifier is to provide evidence that you provided service in accordance with the U.S. Preventive Service Task Force A or B rating and effect under the preventive services identified in the preventive services mandate. This is an informational modifier only. It does not affect your reimbursement. However, for separately reported services specifically identified as preventive, the modifier should not be used. Again, this modifier is used when you can show evidence that it is based on the U.S. Preventive Task Force A and B rating that affect other preventive services. We had changes to our ICD-9 for 2012, which was effective October 1st, 2011. However, there were very few changes, and this is due to ICD-10. However, we did have changes in the neoplasm section, and this was actually requested by the New York Center Cancer Registry. They wanted to be able to identify codes for basal and squamous cells. There was nothing specific enough to capture those codes, so there are now 4 new codes that are being used in 2012. For the respiratory system, we had 28 new codes added. The injury and poisoning revisions consisted of the additions of anaphylactic reaction to each code and the subclassifications. And we had 17 new V codes added, ranging from personal history of certain diseases to acquired absence of other organs and tissues. So we had very few changes to ICD-9 for 2012 because we're transitioning over to ICD-10. So now we'll discuss the CPT changes effective 2012. The changes that took place for 2012 by the AMA, we had 225 added codes. There were 162 revisions. There were 77 deletions, and there were 27 resequence codes. Also, the new instructions and guidelines have also been added to the CPT code manual to help clarify coding in a variety of situations. So providers, we had tons of revisions for 2012, so it's going to be imperative that you look at the descriptions of each code that's been revised, because it may include or exclude certain procedures and techniques. In this slide, we have the decision tree to decide if a patient is a new patient versus an established patient. The decision tree is not a new decision tree. It is updated to include the text to clarify the subspecialty. A new patient is one who has not received any professional services from the physician or another physician of the exact same specialty who belongs to the same practice within a 3-year period. For 2012, the initial observation codes, CPT has revised the initial observation codes ranging from 99218 to 99220 to include typical time. Previously, these codes did not have typical time assigned. So as you can see, each of the codes now has specific time. The typical time assigned to the initial observation codes mirror the times associated with the hospital inpatient services. Also, under the new guidelines, these services may be performed by other qualified healthcare professionals. Again, not just physicians. So if you are a other healthcare qualified professional, you can now perform these codes as of 2012. The 2012 CPT changes for the prolonged services. For the 99358, the revision was to remove face-to-face and add direct patient care. So the provider does not have to provide face-to-face care. And the 99359 is for each additional 30 minutes. Again, all prolonged services can now be used by any other healthcare professional or qualified healthcare professional. Now we're going to talk about the 2012 CPT changes for the surgery section. Under the integumentary system, we had several deleted codes. And here on the slide, it outlines the sections and the codes. So we had a total of 26 deleted codes, and it's really affecting the skin replacement and the grafting. So physicians, please go back to your CPT codes and review these codes to see if there are crosswalks that you can use, because these codes are no longer valid as of 2012. Now we'll discuss the 2012 CPT changes for repairs and skin replacements. A repair is a closure. The instructions for listing services at the time of the wound repair have been revised to instruct individuals to report modifier 59 rather than modifier 51 when reporting repairs of multiple wounds. For the skin replacement surgery, the skin replacement surgery section has been extensively revised with new guidelines and definitions. There is now a new subsection for skin substitute grafts. This section includes several new codes. Again, provider, if you're using these code ranges, I recommend that you revisit your CPT manuals for 2012 to have a full understanding of the changes. On this slide, we have 2012 CPT changes for multiple sections. However, the musculoskeletal system had revisions more than deletions. The respiratory system had 7 deletions and revised codes. Cardiovascular, 22 revisions, only 5 deletions, which is good considering all the deleted codes we've seen in the past. The hemic and the lymphatic system, there were no major changes, just revisions. And our digestive system only had 2 deleted codes. Again, providers, there were tons of revisions throughout the entire CPT coding structure. It's very important to go back and look at the codes that were revised. Again, they may include, exclude, and some procedures may be bundled into the new revisions. So again, look at your revised codes. We're continuing with our 2012 CPT changes. We have the nervous system. There were 17 revised codes, 2 deleted codes, and 6 new codes added. Under the radiology section, we had 8 revised codes, 18 deleted codes, which are really due to respiratory, 10 new codes, and here's a list of the codes that were added. Under the CPT 2012 changes for radiology, we have 2 examples of 2 revised codes. We have the 72144, which is the radiology examination, spine, lumbosacral, complete, including bending views, a minimum of 6 views. We have the 72120, radiology examination of the spine, lumbosacral, bending views, 2 or 3 views. Again, it's very important that you read the revised codes. For 2012 CPT changes for pathology and laboratory, we had a large variety of new codes added. Practically 102 codes were added. We had 2 deleted codes and 5 revisions. A new tier section has been added to the pathology and laboratory section to describe the molecular pathology procedures performed to detect and analyze gene variants for constitutional or neoplastic conditions. There are extensive instructions in this new section to provide guidance in using the new codes appropriately. 2012 CPT changes under the medicine section. We had very few changes that were affected. Under the immunization, 90470 and 90663 was eliminated. We had a few changes under ophthalmology, cardiovascular, and pulmonary. For neurostimulator, codes 95972 and 9582 really was revised to define simple versus complex programming. For 2012 CPT changes for the immunization administration, again, 90470 for the H1N1 has been deleted. For the 2012 incentive programs, providers, there may have been changes to the EXR incentive program, the EHR, and the PQRS. I would visit the CMS website to find out if there were any major changes that affect these incentive programs. I thank you for your participation, and I'm going to turn the program back over to Jeremy.
To wrap this up, this is the resource slide that Wendy was referring to, and here we have some URL links to relevant topics throughout today's discussion. That concludes our webinar. We'd like to thank you for participating, and we look forward to seeing you at our next webinar.